Hello, everyone. Hope you're doing well. So we'll get started with the ADC practice paper that they recently released on their website to help the candidates who are going to sit the ADC written exam. All right. Now, what I've gone through the entire practice paper, and I would believe almost 95 to 98% of the questions that are there in this practice paper are present in the course portal already. All right. So I'm not sure why some candidates they were panicking that these are new questions, but they are not actually new questions. All right. The first thing. The second thing is that ADC has released this paper in order to help the candidates see how the questions are in the exam. All right. Those who have sat the exam, they would already know most of it. But those candidates who are sitting for the exam for the first time, they understand that the clarity that the ADC gives you in the questions is much more, all right, which makes it a bit more easier for you to select the right answer, all right? So that's something that you should keep in mind, all right? It's good for review, of course. And to tell you very frankly, it's pretty easy and pretty straightforward, the paper that the ADC has released. There can be two reasons for that. One is just to give you the candidates an idea on how the paper will be. Secondly, ADC purposely does not disclose the difficult questions. All right. And I would even go to this extent and say that this paper is much easier than the mocks that we conduct. All right. So, candidates who have attempted this paper, if you're doing it as a self assessment, you should be scoring quite high. All right. Because the ADC practice paper is not really hard. And like I said, it's very much easier compared to the mocks that we have conducted and that we will be conducting. All right. Now, the other clarity that has been received is that because ADC has given you the answer key, the exam keys for the questions that they have included in the practice paper. All right. Now, this is really important, right? Because certain candidates, they ask me sometimes that why have I selected this particular answer in the course portal, the mock exams, or the ones that you have in the portal, the ones that we conduct, and the ADC past questions that we have in the portal. So certain times the candidate asks me that why I've selected this particular answer. Now the candidate must have realized, especially those who have joined us from other academies, who were with other academies before. Now they will understand why I have selected the answer in a certain way for certain questions, all right? And then the ADC practice paper proves that, okay? The other thing that I believe the practice paper helps you with is that you see the case data that they give you, the clinical picture they gave you, the options that are available for you to select are more complete, gives more clarity to you in selecting the right answer. Because sometimes when you see us discussing the mocks and the questions that you have in the portal, we base our discussion or base our files on the feedback that the candidates who sat the exam gave us. But of course, there is always an opportunity that the candidates, when they give us the feedback, they miss certain important things that are actually present in the question data or the question statement. All right. But now with this paper, you will realize that ADC does not keep the candidate confused. They give you the complete clarity on how you will be able to select the right answer. All right. So, for example, treatment options, patient case data, patient medical history, patient desire for a particular treatment, all this is very clearly given in the question. All right. And that's what I realized through the practice paper that ADC does not leave you in ambiguity. It always gives you ample data and sufficient data to arrive at the right answer. All right. And now the other thing that the candidates ask me is that will ADC, include the same questions in the future exam? Now, ADC is not going to include the exact same questions that are there in the practice paper, but of course, similar questions with similar theme will be included, and that has happened in the past as well. I think few years ago, ADC released a practice paper before the format was changed, and they did the same thing. In fact, at that time, they even included the questions from the practice paper directly in the exam. So you cannot trust ADC with all these things. They might just pick a question from the practice paper and include it in the actual exam. All right. But if they don't do, that does not mean that similar questions with same theme will not be asked in the exam. This practice paper is a great learning resource, which I already mentioned in the WhatsApp group. It's a great learning resource. Everyone who is attempting the written exam should take it very seriously. All right. And the other thing is that some candidates say, all right, if these questions are, let's say, not going to be included, then what about the course portal content? Now, I don't know why candidates are asking me this question, because this practice paper has roughly 200 questions, which is about 30 to 40 case scenario. Now, the course portal that you all have access to has roughly around 800 to 900 case scenarios, which means around 5,500 to 6,000 questions. So I don't understand what is the comparison here. If the ADC has included, let's say, 30 to 40 case scenario in this practice paper that they have released, you still have so many questions that are there in the course portal which are not there in the practice paper. Like I said, around 800 to 850 to 900 case scenario based that are there in the course portal. This practice paper only has around 30 to 40 case scenario. All right. The mock exam that we have in the course portal, the ADC past questions collection that we have in the course portal, the live mock exams that we conduct. So this is just 1/10 of what is there in the course portal. All right. So I wanted to clarify these things because once the practice paper was released, candidates started asking me these questions and all. So I hope this is clear to you right now. All right. Anyone would like to ask me any questions before we get started with the discussion? All right. Someone is saying some question answers were a bit confusing, so we need your clarification, please. Yes, that's the reason why this session is being conducted, right? Uh, to help you answer those questions. I'll be going through each case scenario. So don't worry about that. All right. But of course, I'm not going to pause at each case scenario. All right. Those questions, which are pretty straightforward, I'm just going to go through them in a quick way so that we have more time to discuss on more important topics and the confusing questions. All right. Anyone has any other question before I get started? All right. So let's get started. Are questions connected to each other in one scenario? Most of the time, yes. Sometimes you might have an independent question, which we can see here as we go through the practice paper. All right. All right. Any other question that you have, just post it in the chat section and I will be reading them as well. Okay. So you have first case, Nancy, 45-year-old, tooth pain every now and is unhappy with the way her teeth look. Last dental visit 6 years ago. No obvious dental disease. Taking beta blocker for hypertension started 3 years ago by her general practitioner. All right. This is the clinical picture. She is keen to regain her oral health so she can eat properly. Most likely explanation for recent deterioration in her dental health, changes in her saliva, of course. Nancy indicates that tooth 3 gives her pain every now and then. So tooth 3. In addition to pulp sensibility testing, using dry ice, what clinical investigation would most assist in making a diagnosis? Percussion testing. What restorative principle is the most appropriate important in ensuring a favorable prognosis for tooth 2-3? All right. Now, if you look at tooth 2-3 here, this is the one, right? This is the one that they're asking. So the question asks you, what restorative principle is the most important in ensuring a favorable prognosis for tooth 2-3? Favorable prognosis means that tooth survives for a long time, good long-term future. All right. Now, if you'll see in certain answers, I've given further explanation in the form of text next to the answer itself. All right. And if you see here, a marginal seal prevents micro leakage, which is the main cause of recurrent caries, post-op sensitivity, and eventual failure of the restoration. While important partial caries removal is sometimes preferable to deep lesions to avoid pulp exposure, especially in modern minimal invasive dentistry. Established canine guidance, this is relevant in full mouth rehab or occlusal planning, but not the most critical factor in the prognosis of a single restoration or grossly decayed canine. All right. So this explanation would help you understand most of the options why they have not been selected. All right. Total caries removal, if you have read the caries article, total caries removal is not the most important thing. Sometimes we have to be conservative to protect the pulp. Last mock exam discussion session, the same thing I told you, right? And now also please remember that when the answer is selected here, don't question the answer. ADC answer key, you cannot question them that the ADC has marked them wrong. All right. You have to accept the answer as it is, but you need to know why that answer has been selected. All right. And that is the purpose of this session. So don't ask me that this is wrong and this answer should be selected. No, whatever the answer key, it's right. And I've gone through the entire paper. All the answers that the ADC have marked are completely accurate. All right. The next question says Nancy asks you for full mouth vital tooth bleaching as she has been advertised, as she has seen advertising which has convinced her that she needs to have it done. If Nancy opts to proceed with it, what is the most appropriate stage of treatment for her to have this done after the placement of temporary restoration? Because you cannot do the permanent restorations until the shade selection has been done. She is interested in having teeth 1-4 and 1-5 replaced with implants and crowns. Her friend had it. She was happy. What is the most likely issue that may impact the ability to proceed with implant placement for Nancy? Now, the answer is bone quantity may be inadequate. All right. Now, why this option has been selected? Because certain candidates might say that option D also makes sense. Now, here in the explanation, if you see, D can be true as well, but D basically affects how much bone we have. So the direct effect is less bone quantity. Also, it doesn't look like a recent extraction, so a fair amount of resorption might have taken place. Okay, so that is the reason why option A is selected here. The bone quantity may be inadequate for the placement of implants in the region teeth 1-4 and 1-5. All right, and the complete case is there in the portal with explanation as well. You have next case, Betty, 70-year-old female, for a checkup. Recently widowed, lives in a residential care facility with fluoridated reticulated water, drinking bottled water rather than tap water, doesn't like the taste of it. She has Sjogren's syndrome. You saw multiple root caries. Betty has viscous saliva, low saliva flow, and low acid buffering capacity. What is the most important part of Betty's patient history to consider when determining Betty's caries risk factor? History of Sjogren's syndrome, very important. You found white spot lesion on tooth 1-1 in cervical region, non-cavitated lesion. Addition to providing oral hygiene, what is the important management for this lesion? Topical application of remineralization agent. What other supplemental oral hygiene care regimen you can provide to Betty? CPP, ACP. All right. What is the most important action to take to decrease the caries risk for Betty? Provide advice on how to alter modifiable caries risk factors. Regarding the bottle intake that she has, Betty should drink bottled water containing fluoride. Again, same case, same discussion we had in one of our previous mock exam. Why not D for question 8? It's asked about managing her caries risk, not dry mouth, right? So always read the question very carefully. Like I mentioned so many times, majority of the candidates fail the exam because they don't read the question properly. All right. Question 9, someone is asking, can we choose D? Conduct a dietary analysis. Now, if you're conducting a dietary analysis, you're just targeting one aspect of management. Option B says alter modifiable carries risk factor, which includes more than one factor that you can modify, right? You have Andrea, problems in mandibular third molar, episode of pericoronitis. She is immunocompromised. What is your recommendation to Andrea as the most appropriate mouthwash as part of the management of her painful wisdom tooth? CHK, CHX, chlorhexidine gluconate mouthwash. You gave penicillin, she came to you with itchy rash all over the body. What is the next important thing to do? Prescribe her antihistamines. First choice of removal, OPG. What medication for surgical antibiotic prophylaxis you will give to Andrea? Clindamycin 600 mg 1 hour before the surgery. It will be 2 weeks until you can see Andrea for the removal of the tooth. Local management that you will do, local debridement of the operculum and irrigation with 1% hydrogen peroxide. All right. Again, the entire case is in the portal. If you have any doubt about any particular question, just write it in the chat section. And like I said, I will go through all the questions quickly because this practice paper, like I said, you need to make sure that you have gone through it before so you know what the questions are. Because the purpose of this session is to discuss those questions that are confusing for the candidates. All right. Now you have Brian, 30-year-old electrician, rarely visits the dentist, slight discomfort, right mandibular area, continuous dull ache, and he seeks your advice now. Insulin for type 1 diabetes, well controlled. You took a panoramic radiograph, OPG, and that's here. What complication has affected the adjacent teeth as a result of the presence of the radiolucent mandibular lesion? So what has happened is external resorption of tooth 4-7, as you can see here. The roots have been resorbed. What is the most likely diagnosis for Brian's presenting symptoms? Keratocyst odontogenic tumor, OKC. Additional imaging, CBCT, very important. You informed Brian that any increase in the size of the lesion could have serious consequences. What is the most conservative management to recommend for Brian? Now they're asking for conservative management, enucleation and extraction of tooth 4-8. Option B is sometimes used in addition to enucleation, right? Especially in large or recurrent lesion, but not the most conservative first-line approach. You see another mandibular radiolucency around the roots of tooth 3-8. Most appropriate initial course of action, do a pulp testing to see what is the status of the pulp, whether the radiolucency is related to pulpal infection. Four seven has not been displaced, all right? 4-8 has been displaced. This is tooth number 4-7, okay? And the arch symmetry is intact, right? If you see these 3-6-3-7 and 4-6-4-7, they're on the same occlusal plane. So that means displacement of 4-7 has not occurred, as someone is asking in the chat section. All right, next case. Miss Catry presents for a checkup. No problems. She has a large number of resin composite restorations. You decide to obtain a bite wing radiograph. The right side is shown. On examination, the right bite wing radiograph, you note a radiolucency affecting the distal surface of tooth 4-6. What symptom would Miss Cattry be most likely to indicate she's experiencing in relation to this tooth? In relation to this tooth, what would be the symptoms? No sensitivity. All right. Now, why no sensitivity? First of all, yeah, I'll answer that. Someone is asking me in the question section. Now, first of all, if you see the radiolucent lesion here, what are you seeing here is basically radiolucency, probably due to the chipping off of the restorative material. The part where the pulp is, or the part where the tooth structure is still covered by the intact restorative material. So this would not really cause much trouble to the patient, and the patient might not really be aware. And that's the reason why the patient came to you with no particular complaints, because this is something that you saw on the bite wing radiograph. The patient is not really much bothered about it, or in most case scenario, the patient might actually not know that this exists. All right. Now, going further onto the same case, now let's say if the patient came to you telling you that she feels food impaction and pain in that area, and you have a similar radiograph like this, then your answer changes from no sensitivity to sensitivity to biting pressure, right? Because of the food impaction, the gums is irritated, food collection is going on. When the patient's bite, it hurts. Okay? So just to give you a further idea. What factor needs to be considered whether to surgically manage mesial surface of tooth 4-7 and placer restoration? The presence of cavitation, right? If there is a presence of cavitation, that needs to be restored. Further examination of the radiograph, where else can the radiolucency be detected affecting enamel and dentine in an unrestored tooth that will need to be managed? Distal surface of tooth 1-5. So that would be this one, right? Distal surface of tooth 1-5. What approach would be most appropriate or effective in making Miss Cathry's enamel less acid soluble? Brushing twice a day with a 1200 ppm fluoride toothpaste. A, B, C, D does not make sense. Main technical problem with the bite wing radiograph, the patient failure to occlude on the film holder. The patient has not actually occluded, all right? Can you see the space here? For question 24, can we choose C for 24? C is increased daily water intake. Okay. Now again, you see, the thing is that read the question statement, what it is asking, right? If your overall management of Miss Cattry's early carious lesion involves treatment to encourage remineralization, what approach would be the most effective in making Miss Cattry's enamel less acid soluble? So, what amongst the option makes the enamel less acid soluble? Increase daily water intake. What is it going to do? So, sometimes when you have doubt, read what the question is asking. I've mentioned this so many times, you might see that many options might seem to be correct initially, but when you read what the question is basically asking you, the answer changes and it becomes very straightforward. And that's the reason in the start of this discussion session, I told you that the ADC provided this practice paper, which is very straightforward and giving you clear instructions on how to select the right answer. In the exam, that might not be the case, right? All right, let's move to the next one. For 24, it says increased consumption of cheese and milk in our diet. Like someone is asking me why not that option. I just explained to you increased consumption of cheese and milk in our diet will help increase salivary flow probably and possibly help in remineralization. We want to make the tooth stronger and make it less acid soluble. How does B help? Okay. Okay, next question. Healthy 45-year-old woman. Abscess related to tooth 3-6. Foul taste. The tooth feels heavy and uncomfortable, but she has not experienced severe pain, a fever, or facial swelling. You saw the patient 12 months ago where you partially extirpated the pulp, dressed the radical pulp with calcium hydroxide, placed glass ionomer cement. She was traveling, so she couldn't continue the treatment. Temporary restoration on your observation has been dislodged. Evidence of caries under the restoration and chronic fistula around the furcation area. You also take periapical radiograph and compare it to the periapical radiograph taken 12 months ago, figure 1. So 12 months ago X-ray, today's X-ray. All right. So what we are seeing here is what is the most likely reason for the difference in the appearance of the bone in the two radiograph? Chronic localized infection, which has led to the bone getting involved. Okay. Foul taste can be due to pus, of course. Secondly, it can be due to food impaction as well. In addition to the periapical radiograph you have taken today, what other investigations will provide you with the most relevant diagnostic information? Periodontal probing test, all right. You advise Miss Ibrahim that extraction of tooth 3-6 is her best option. She wants to know if an edentulous space can be left. What further information would be required to best assist in responding to Miss Ibrahim's question? Occlusal stability, which means if she has sufficient units that can be considered if the patient wants to have the edentulous space left like that without replacement of the tooth if extraction of tooth 3-6 is done. Now, the thing is that this tooth has already been RCT treated, right? And you place calcium hydroxide in 12 months prior appointment when the patient came to you. Percussion test, what will it tell you? The question says, in addition to the periapical radiograph you have taken today, what clinical investigation will provide you with the most relevant diagnostic information regarding Miss Ibrahim's tooth 3-6? Why periodontal probing? It will help you see if, first of all, any fractures, VRF involved, furcation area involvement. All right. Percussion test, okay, you do it. What is that you're going to gain? You have taken up the pulp, all right. Maybe there might be no response to the percussion. So you have to see the case scenario. It does not mean always you select the percussion test as the priority. In most cases, yes, the patient comes to you, they say that what is the initial investigation you will do, percussion, what is the best investigation for pulp, sensibility testing, best investigation for diagnosis and treatment plan, IOPA. But of course, it all depends on what the case is asking you, right? So if you use a bit of clinical sense, let's say this patient comes to you, all right, and you have the same scenario. Very often these types of cases we see daily in day-to-day practice here. You've done something, the patient does not come to you for months and then comes and returns with pain or problems like shown in this case. What will I do, do you think, or what will you do? Will you percuss the tooth? Like what additional benefit are you going to gain? It says the investigation that you select should give you most relevant diagnostic information. So does percussion fits the criteria of most relevant diagnostic information? So always think like this, right? The purpose of the course, the purpose of the discussions, the mocks, the live mock exam, past questions collection, we have so many hundreds of files in the portal, is to change the way that you think. All right. It's not to make you a dentist. You all are competent dentists. Okay. So you are not a student studying dentistry. You just need to emphasize on the theoretical knowledge that you have and convert it into a clinical outcome. All right. All right. So then she says that if I want to just extract and leave the edentulous space, what further information will be required to best assist in responding to Miss Ibrahim's questions? So, what is Miss Ibrahim's question? Is this? This is her question. She wants to know after extraction, can she leave the edentulous space like that? Okay. She asked you about surgical complication. What is the most likely complication that may be encountered during the extraction procedure? Fracture of the root. Of course, we don't have much of the coronal structure. This is entire filling. When you try to extract this tooth, this portion is going to break off, possibly leading to a fracture of the root as well. All right. And again, if you look at the options, it's pretty much obvious. A, B, C, and E does not really make sense over here. Why not D? D for what? Which question? Please mention the question number as well. All right. What is the best way to manage the extraction of tooth given the presence of periapical and periodontal infection? Post-operative instructions, including rinsing with salt water. A, B, C, and D are wrong. Why not D? Question 29. D is the answer. Inability to obtain adequate anesthesia. Now, you see, again, I'm telling you the same thing. This is fifth, sixth time in the same session I'm telling you. She asked about surgical complications. What is the most likely complication that may be encountered during the extraction procedure? Please read the question. The question has the answer. If you understand the question, half of the job is done. And like I said many times, most of the questions, not even in this practice paper alone, in the mock exam, live mock exam, you answer the question wrong because you don't understand the question or you overlooked what the question is asking you. That is my reason for number one failure of the candidates in the written exam based on experience of almost 9 years. All right. Candidates do not fail because they don't have adequate knowledge. They fail because of not knowing what the question was actually asking, right? So inability to obtain adequate anesthesia, like someone was asking me, can be an answer. Yes, she has an infection, although no swelling. So we don't really anticipate that anesthesia might not really be effective, but can be an answer. But the question is not really asking you that, right? 30, why not C? A single preoperative dose of an appropriate antibiotic. Okay, so justify to me why would you like to go for C? If your justification is acceptable or I'm happy with that, I'll opt for that question or opt that answer option. So who asked me 30, why not C? Can you justify why you would want it to be C? All right, a single preoperative dose of appropriate antibiotic, not really needed. For what? Okay. That's like basically giving a prophylactic surgical antibiotic prophylaxis. Why do you need it? There is no indication for that in this case. Okay. 30, why not C? Because there is an infection. Uh, so if there's an infection, that means that you give them surgical prophylactic antibiotic. Is that an indication according to TG? Every tooth that has an infection should be given surgical antibiotic prophylaxis? No, right? But in fact, TG goes as far as this, that if there is even a localized swelling, this patient doesn't have a swelling according to the case, but it goes as far as this, that if the patient has a localized swelling, you still don't need to give them antibiotic prophylaxis. And in fact, no therapeutic antibiotic prophylaxis. Antibiotic prophylaxis indication, surgical antibiotic prophylaxis indication, antibiotic regimen for acute dental infections should be on your fingertips. All right. Question 30, why not D? Curettage of granulated tissue and irrigation with sterile hydrogen peroxide. When do you use hydrogen peroxide to irrigate the tooth socket? All right. So part of the statement is correct, but the second part is wrong. It should be sterile saline, right? For irrigation. You can't introduce hydrogen peroxide into the socket, right? It can be hazardous. All right. So look at what the complete options means. That's very important. And that's the reason why I wanted to hold this discussion session, because the answer key is there to help you understand the answer key and to help you understand how to go through the question. ADC makes simple things difficult by doing things like this. All right. We have the next case. Georgia, 52 years old, toothache, lower right hand side. You have a provisional diagnosis of IP, irreversible pulpitis. He elects for root canal treatment for 4/6. You administered a highly efficacious inferior alveolar, lingual block, and long buccal nerve block. 15 minutes. He has the iron is effective. Supplemental injection technique, intraligamental injection technique adjacent to tooth 4/6, as already discussed so many times. That's a supplemental injection technique, right? If option C said a buccal infiltration distal and below the apex of tooth 4/6, if this option said a buccal infiltration adjacent to the apex of tooth 4/6, uh, I will go with that option as the first choice. All right, because there is a sequence on what to do when inferior alveolar nerve blocks are not effective, right? But here, option D makes more sense because of the wording of the statement. Anatomical landmark to locate the floor of the pulp, CAJ, cemento-enamel junction. After determining the working length, 1% NaOCl, you plan to use that. Irrigation technique most likely to improve the ability of the irrigant solution. Positioning the needle tip in the apical third of the root, right? Astatic irrigation is wrong. Positive pressure, we don't want that. We want negative pressure irrigation. Allow the needle to bind slightly to the apical canal walls. We don't want any binding. So option B is the only one which makes sense, right? And I've given some explanation as well here, where it says a static non-agitated technique is less effective. Dynamic methods, side-vented needle movement, sonic, ultrasonic, improve irrigation flow and contact, which means why option A is wrong. Increasing the positive apical pressure with the syringe plunger, dangerous. Increased risk of apical extrusion of the irrigant, NaOCl, which can cause severe tissue damage and pain. Allowing the needle to bind to the apical canal walls, also dangerous. A bound needle may block irrigant flow or cause extrusion. It should remain loose and mobile within the canal. To effectively remove the pulp tissue and biofilm, the irrigant must reach and act in the apical third of the root canal system where mechanical cleaning is limited and microbial lobe is often the highest. All right. So that is the reason for just an explanation, because when I was going through this answer key, I wanted to give some explanation to candidates to understand for future reference, right? Okay, let's move to the next one. With his symptoms managed and healing progressing well, she attends for the 4/6 obturation appointment. You plan to place a resin cement, sealant cement, and gutta perca root filling using a lateral condensation technique. What procedural step in obturating the root canal is most likely to reduce the risk of vertical root cracks and fracture? Exerting axial compaction force away from the canal walls, right? Applying force in axial direction downward along the canal, it minimizes the lateral stress on the canal walls. And then it says why the next A, B, C are wrong. Okay. I've zoomed in a bit, so I think the explanation that I've given is clear. Can you guys see it? To some extent, of course. Yeah, because I couldn't modify this. I'm legally not allowed to modify the paper that the ADC has given. So whatever space I had, it was although very difficult for me to include statements in such small space, but I just tried to give it the explanation so that you have an understanding. After completing the root canal treatment, you're planning to place the final colon restoration. Most important factor will be the adequacy of remaining sound tooth structure. All right, I'll zoom out a bit, and when we have any explanation, I'll zoom in again. All right. So, so far, what we have discussed, I don't think so. Anything is not there in the course portal, in the questions that we have in different forms in the course portal. All right. All right. Let's move to the next one. Rajesh. Oh, that's fine. That's what I'm saying, that this explanation, whatever you have here, you will be provided with the recording. So you can always check that again, right? That's not a problem. 39-year-old male patient who attends your clinic complaining of severe pain. And in fact, what I'll do is to keep it easier for you guys, with the recording, I will also provide you with this solved version, right? With the explanation. So then you can zoom in the PDF file. All right. Okay. Let's go to the next one. Severe pain in the lower right molar region. Saw a local dentist 4 weeks ago for root canal treatment in tooth 4-6, but developed a dull ache shortly afterwards. Please increase in intensity gradually over the past few weeks, 2 weeks. So you have some notes and radiograph. No other previous records are available. His medical gastrointestinal ulcer, which is treated with esomeprazole, Nexium, a proton pump inhibitor. What clinical investigation would be most appropriate to assist you with the diagnosis of Rajesh' chief complaint? Palpation test, percussion, periodontal probing. Same case we had, I think, in one of the last few mocks that we discussed. Someone was asking me, why not sensibility? Why not sensibility? So many academies has answered this as sensibility. Now you understand why not sensibility? And ADC has proven it to you why not sensibility, because we don't need to do it. The tooth is actually treated, right? And whatever pulp is there, your sensibility testing is not going to excite these nerve fibers, whatever pulp or nerve remnants are left. Which irrigation factor most likely contribute to Rajesh persisting endodontic infection? The answer is solution access the canals incompletely. Because how we know that solution access the canals incompletely? Because we can see that most likely this area has not been, number one, debrided, which is more important. Secondly, not obturated. All right. Debridement is more important than obturating. What you take off the canal is more important than what you put inside the canal. All right. No, the thing is that what you have here is, yeah, 2%. That's not a problem. Please remember, in Australia, 0.5 to 5.25% NaOCl is being used. Completely acceptable. Don't worry. When I started working here, my initial owner was so scared. He used to use 0.5% sodium hypochlorite. And then I had to convince him, please increase the concentration. It makes our life easier. All right. But yeah, from the textbook standard, from 0.5 to 5.25, that's acceptable. All right. Which root filling related factor contributed most likely to endodontic treatment failure? The incomplete root canal obturation, right? Which is option B, because we can see that it's definitely incomplete, right? You notice a reducence in the furcation of Rajesh tooth 4-6. What complementary imaging modality? CBCT, of course. You are unable to provide Rajesh with dental treatment within the next 48 hours. What analgesic regimen is most appropriate to manage his symptoms? He is not allowed to take NSAID, active gastrointestinal ulcer, taking proton pump inhibitors. So you're only left with option E, oxycodone and paracetamol. All right. So the thing is that this question, although we have it all in the exact same question in the course portal, but when you see the wordings, why I emphasized earlier is that the clarity that the ADC has presented is amazing. All right. Why? Because the question actually tells you where to select the answer and what answer to select. I'll just tell you how. It says which irrigation factor. It is not asking you what has led to Rajesh's persistent endodontic infection. They are very specific. Which irrigation factor? The same again. Which root filling related factor contributed most likely to endodontic treatment failure? Okay. Now, why I'm emphasizing on this, certain questions you have in the portal, when we get the feedback from the candidates, they tell us the question mentioned what is the cause of the pain, or what is the cause of the failure, or what is the cause of the persisting endodontic infection. And I have answered those questions according to that in the portal. But when you see here, which I believe did exist in the paper, because of course the candidate does not remember everything once they sat the exam and they give us the feedback. When you see statements like this, it becomes so nice and easy for you to select the right answer. All right. 38, the sealant's lack of bonding to dentine. Why? Why would sealant's lack of bonding to dentine would be a factor to the endodontic treatment failure? We are not really concerned about that, right? We are more concerned about the incomplete root canal obturation. So if you have a better option than A, why would you like to go for A? On a safe side, yes, celecoxib is a non-selective, but if you go to the previous page in TG, it says avoid NSAIDs, especially in people who has a gastrointestinal ulcer, all right? An active gastrointestinal ulcer. All right. Next case, 25-year-old laborer, works long duration outside. Emergency patient, upper right region complains of pain. He occasionally wakes up with sore taste in his mouth. David has poor oral hygiene and during the course of the day drinks cola continuously and smokes about 5 cigarettes. Not visited dentist for many years and advised that both of his parents wear complete dentures. All right, the question, sir, is sealer we use for obturation soluble? Now, what do you mean by soluble? The sealer stays in the canal, right? So practically it's not soluble if you're comparing it with intercanal medicaments that we use, which is calcium hydroxide, right? What is the most likely description of David's pain symptom that would lead to your provisional diagnosis of reversible pulpitis in tooth 1, 2? A mild pain lasting several seconds after a cold drink, all right? Again, the question is so clear. It says, what would be the likely description of David's pain symptoms based on your provisional diagnosis of reversible pulpitis? Investigation.
So I have doubt in question 41. So it's usually sharp pain, not mild. I know option D, all other option doesn't make sense. Option D is right.
Mhm.
It's just the mild pain that I'm not able to understand. Else, several seconds after cold drink, it makes sense.
Yes, so
Should be
that's the
sharp
thing.
pain.
Now, yeah, you could have mentioned it in the chat section. I would have answered it, but yeah, it's fine. Now, the thing is that you only have sharp pain on biting, right? Which is not really correct. If you had sharp pain on the consumption of a cold drink, I would go with that option. But unfortunately, you don't have that, right? So you go with the next best option that you have, isn't it?
Done, sir.
So
Done, sir.
that's the reason because A, B, C, and E are wrong, right?
Yeah, yeah,
So that is
yeah,
the
that's one.
reason. Sometimes ADC functions this way to just to confuse candidate. Now, of course, reversible pulpitis is usually sharp pain with cold, with sweets. That's a sharp pain. But unfortunately, you don't have that. So you go with the next best option, right?
Done, sir.
All right. You have the next one. Confirming your diagnosis, best test, carbon dioxide, dry eye stick. Okay, again, this is a very important question now because a lot of candidates tell me that other people have answered it differently. Why have you answered it this way? Now, ADC has proved why I've answered it this way. In discussion with David, you agreed to proceed with restoring his tooth 1 2 at today's appointment. You administered local anesthesia, established a cavity outline, and removed caries at the dentino enamel junction. It then becomes apparent that if you remove all the soft pulpal caries, the pulp will be exposed. What is the best way to proceed prior to placing the final restoration? The answer is remove peripheral caries, create a rim of sound dentin around the pulpal caries, seal in the pulpal caries with an adhesive resin based composite restoration. All right. Now, this would answer the questions that we have in the course portal in the mocks and the live mocks past questions collection.
Right.
Why I have answered this question over there as well, and now the ADC has answered the question in the same way, is because we want to be conservative. We don't want the pulp to be involved. So even if there is soft caries, you create a sound rim of sound dentin around those soft pulpal caries which are left, and then you seal in the pulpal caries with adhesive resin-based composite restoration. The second part of the statement proves why I have always been encouraging in my files to do not relay the definite restoration. Do it in a single appointment. Doing it in multiple visits increases the chances of micro leakage, salivary contamination, and bacterial inoculation. All right. B. B says carry out coronal pulpotomy. C says carry out coronal pulpotomy. D says start RCT. E says remove carious dentine, re-enter the cavity. We don't want to re-enter the cavity again. So how is it, if we are trying to be conservative, protecting the pulp, it's going to be only A, right? B says remove all caries, carry out a coronal pulpotomy. That's why it's not B. We don't want to involve the pulp. Okay. And that is the reason why I last time suggested is to read the 6 caries article that are there in the useful caries folder. They are gold standard articles, and ADC has exactly answered this question according to what is mentioned in those articles. All right. No, technically, if you don't have direct pulp capping, you don't really need to place a base, right? And if you consider to place a base, that would be an MTA, all right, for a direct pulp capping. But we are going even before that. We don't want to involve the pulp. We want to create a sound rim, leave the soft caries, seal it with the permanent restoration, and see how life goes on for the patient. If you want to do something in the future, we can do, but that's what the standard is for now. What about the indirect pulp capping in this case? This is indirect pulp capping. Option A is basically indirect pulp capping, right? So you're leaving the dentine above the pulp and you are just covering the area with restoration. So this is something like indirect pulp capping, right? Okay. But we are not using any agent, like we are not using any therapeutic agent, a pulp capping agent. But if option A had pulp capping agent, you can use that as well, right? A pulp capping material can be used, all right? It's going to be MTA, but ADC has not given it, so that's fine. But it doesn't really matter if they have given it or not because B, C, D, and E are wrong. So you're only left with option A, all right? Now, why I wanted to emphasize here and why I stopped in this question is because the thing is that when I see questions, usually I avoid all these social media platforms, Facebook and all that, but certain candidates send me and then they see the same question, exactly same. A lot of people, I'm not going to name any mentors or anyone, a lot of people have answered this as option B, some has answered it as option E. So this is completely wrong, right? That's why when ADC gives you a reference to go through, when the ADC is telling you this is what our reference are going to be based on, and this is how we are going to mark you, then it doesn't make really sense, right, to follow something otherwise. Okay. So when the Carey's article have specifically mentioned what you need to do, and that's A. So I don't really know why everyone, maybe they're not aware about these articles, maybe they are following conventional methods which are there in textbooks, which are no longer applicable for ADC. So please be very careful and don't send me pictures from Facebook or pictures from any other social media platform. I'm not really interested in that. I'm not really interested on what others teach. I'm more concerned about my candidates and how I am teaching them and what resources I have provided. If you have a conflict with that, if you disagree with my opinion, you can always ask me question. I'll prove you in most certain cases why that answer has been selected. So I'm never blindly, I don't want you to blindly just follow me. All right. The only reason why I want to you is to follow what the resources say, what the criteria says, and how the ADC assesses and what the ADC wants you to select the right answer. And I'm really happy that the ADC released this practice paper, because a lot of questions where there were ambiguity, they have been clear, and these answers exactly match what the answers that we have in the portal. If there was an option of indirect pulp capping with MTA and option A, then that option should have been selected, which had an MTA option as well. All right. Okay, David returns to your surgery for a comprehensive examination as he has now concern about his overall oral health. Aside from the poor oral hygiene, what is David's main Caries risk factor? High sugar intake. As it is mentioned, his habit of consuming cola drinks. Again, how to do the restoration of mesoocclusal cavity, sexual matter system, and incremental placement of composite. I think we had a couple of questions like this in the mocks. All right, Umar, 34-year-old Aboriginal man. Yes, now this question is also very interesting and very important, right? What this question did is it created so much awareness on what the exact question is. Okay, because we have a few versions of this in the portal. Indigenous community and speaks little English, 14-year-old son who acts as an interpreter. Pain, the father has been in pain, fit and healthy, never been to a dentist. You explain the need for a radiograph to the patient, why his son, and take a periapical radiograph of Omar's lower left molars. What is the most important to consider when assessing whether it is appropriate to use Omar's son as an interpreter in these circumstances? And the answer is relatives may not translate information accurately. Now, the question asks you what is the most important to consider when assessing if this child can be used as an interpreter in this circumstance, right? So A, B, D, they are completely wrong. An indigenous 14-year-old son is considered a mature minor. Now, 14-year-olds can be considered a mature minor, but the word an indigenous 14-year-old, that is wrong. It doesn't mean that only the indigenous 14-year-old can be considered as mature minor, right? This is an emergency? Not really. It's not an emergency, right? Emergency is something that is life-threatening. This is urgency. A mature minor can become a translator, and but that would change the statement of the question. Then the statement of the question would be, why do you consider his son to be used as an interpreter? Then you can select if the question said 14-year-olds can be considered as mature minor. So it basically is the play of the question statement. All right. Having examined what is the most likely cause of this feature, okay, now this was a bit confusing because ADC has not given you any X-ray in this case. But I think we had an X-ray in the portal question, which was the same question. So there was a titanium plate, right, which was the radiopaque structure that you can see. But I think there is no X-ray here. So a bit laziness on ADC part, but we can't do much about it, right? I think there is no X-ray, right? Or is this my version where there is no X-ray? Is there an X-ray? No X-ray. All right, that's fine. I was just thinking maybe it's just missed from this file that I have. All right, that's good. Okay. Uh, Technically, yes, it should have been, but of course, you will be having the X-ray where you can see what is happening, right? So it's like a plate which is there. Even if the history mentions or does not mention, that won't make much of a difference because you will see clearly. The exact question is there in the portal. You can see how the X-ray is, right? I've given you a visual description on how the titanium plate will look on the X-ray. So endocarditis prophylaxis regimen, because he has a history of rheumatic disease, option A. Yes. You're concerned about the overgrowth of the soft tissue associated with the broken down tooth 37. Your provisional diagnosis is chronic hyperplastic pulpitis. What is the most appropriate action to take to confirm your diagnosis? Extract the 237, send the hyperplastic tissue to an oral pathology laboratory. Please mute your microphone, don't speak in between. Thank you. So you extract, send the soft tissue to an oral pathology laboratory for confirmation of your provisional diagnosis, right? Because it's here, you are considering extraction of 237. Okay? The question is telling you are considering extraction of 237. Yes, someone is asking me, there is a similar question about hyperplastic pulpitis on portal. We chose C. Yes, because the question was different there. Now the question has gained clarity, and that's why I said initially when I started the session, because of the statements in the question data, it gives you more clarity on selecting the right answer. No, you can take the soft tissue and, because you're extracting the tooth, right? So you can save the soft tissue in a formalin solution and then send it to the laboratory, oral pathology laboratory. If extraction is not mentioned, then we will go with C. Someone is asking me. Now, again, it will depend what the question is asking you, right? ADC will change the question statement to help you select the right answer. Okay. So it's not going to be like this. The ADC sets paper with common sense included in it. They're not just going to give you a vague question like that. And that is very important. And that's the reason why this paper has created so much clarity on what the actual statement is. Because it says that you're considering extraction of 237. Someone is asking me why not C? C says do the root canal treatment, right? You also observe radiolucent lesion associated with the distal root of 236, pulp sensibility test of 236. All right. Okay, next question. Pain on my left upper teeth and gums feel swollen around the tooth, unable to sleep last night. Medical history of HIV, latent TB, positive tuberculin test. All right. What is the most important factor in deciding to proceed with standard precaution? Because he has latent pulmonary tuberculosis. Again, this question is again very interested. Again, the same question when everyone is telling me others have selected the different way. The previous course that we took had different answer. Now you'll understand why it is I've selected E here. On examination, you note a swelling in the upper left buccal sulcus. The 2-4 is a retained root that needs extraction. What additional information is required to assess whether he needs standard or surgical aseptic non-touch technique ANTT for the extraction procedure? All right, that's what the question is asking. And the answer is take a periapical radiograph of the retained root, which will help you assess the degree and the difficulty and the complexity of the extraction. All right. Is E for question 51 wrong? Staffs are vaccinated against tuberculosis. Maybe it's not really wrong, but The question is not asking you that. The question is asking you what is the most important factor in deciding to proceed with standard precaution. So, why do you want to go with standard precaution? Because he has latent tuberculosis. If he had active tuberculosis, the standard precaution changes to transmission based precaution. All right. Question 51. Yes, that is again, you are answering your question in the answer itself. It says, why you are asking me why not A? HIV also we use standard precaution. Yes. So for us, it doesn't really make a difference whether the patient is HIV positive or HIV negative because in both instances, standard precautions are used. The question is asking you what is the most important factor in deciding to proceed with a standard precaution? His HIV infection, whether positive negative, doesn't make a difference to you, but his latent pulmonary tuberculosis makes a difference to us, right? Because if this was not latent and active, then it would be transmission based precaution, isn't it? That is how ADC plays. Please be very careful. I want every candidate to pass the exam. Every candidate that is in our course, I want them to pass the exam. So I don't want you to make these mistakes, silly mistakes. All right. Of course, I don't want you to be very quick in, picking. Of course, I have been teaching for 8, 9 years. So for me, it is very easy to see how ADC plays. But when you practice so much and you involve yourself in the preparation, it becomes easier for you to pick as well. All right. Again, assume you had an infection with hepatitis C. What is your responsibility prior to extracting minerals tooth? Of course, have medical clearance from your doctor to undertake exposure-prone procedures (EPP). So 2,4 has been extracted and disposed of following the relevant Australian standard. Considering manual's risk factor, into which waste category should you dispose of the bloody gauze, right? Now I'll give you a minute to read the explanation and then ask me any question you have. All right. Now you understand why we have included clinical, right? Contaminated, not a formally recognized category under Australian guidelines. Contamination is addressed within the clinical waste classification. All right. When we have boxes here in our clinics, usually we have the box, which is the yellow clinical waste bag, right? That is the clinical waste. And that's where we put it. That's the reason why ADC has collected clinical for those who are have exposure to clinical dentistry in Australia and for those who are working. And in my clinic as well, we have yellow boxes where we dispose of our gauze, bloody gauze, cotton, whatever has gone inside the patient's mouth, right? All right. You advised to maintain excellent oral hygiene, book an appointment for comprehensive examination. What lesion should prompt you to alert his medical practitioner? Hairy leukoplakia, of course. It is one of the sign of AIDS, acute immunodeficiency syndrome, right? Amanda Rogers, 76 years old, kept her up at night. Do you normally require antibiotic cover before dental treatment on her medical form? She ticked yes. What condition would necessitate the use of antibiotic prophylaxis for Amanda? Again, this question was of ambiguity to so many candidates. Why in the portal I have answered it as patent ductus arteriosus. Now you'll understand why it is patent ductus arteriosus, and ADC agrees with me as well. All right. Medical form, following medical condition: high BP, stroke, smoker, emphysema. What is the current ASA classification? Is ASA 3. All right. There are two charts in the portal with the ASA classification. Pretty easy to pick up, but make sure that you are competent enough to understand the ASA table, right? Don't memorize it completely. I would say at least understand what falls under ASA 2, 3, and 4, because the patient is never ASA 1. Because if he is ASA 1, ADC will not ask you that question. Amanda indicates she is taking warfarin to prevent a second stroke. INR, pretty straightforward. Okay, you take a panoramic radiograph which reveals tooth 4A to be carious. You assess the tooth on the image. The radiological sign indicates the highest risk of nerve injury during third molar surgery. All right, let's zoom in this. All right. So what it says here, narrowing or constriction of the inferior alveolar canal suggests intimate contact or encroachment by the roots of the tooth 4/8. This is considered one of the most reliable radiographic indicator of high risk of iron injury during extraction. It may imply loss of cortical boundary between the root and the nerve canal, suggesting root proximity or contact. Interpretation of lamina dura or of the inferior alveolar canal may indicate contact, but not as specific or reliable as canal narrowing. Superimposition, not really. In large pericorneal space, periodical bone sclerosis does not have any relevance. All right. I'll understand why I have selected B here as well as in the portal answer key. Imaging modality before removal of third molar, CBCT. All right. Because you're concerned about the risk of nerve injury. All right. What we have, the next case, Suarez, pain in tooth 2/6. Not believer of mainstream dentistry, wants holistic dental practice. You take a history of the issues related to tooth 2/6. What is the most important type of information you would gather from Ms. Suarez to assist in developing a diagnosing of her presenting complaint? Pain history, of course, which will tell you where you are leading the case towards or where you're leading to the diagnosis. Based on the clinical photograph, what behavior or habit would be most relevant? Dietary composition, of course, that's the most relevant for a decay of such extent to be formed. Following completion of comprehensive patient history, what is the most valuable clinical investigation to assist you in reaching a diagnosis? Pulse sensibility testing. While conducting your clinical examination, you notice several white spot lesions. You suggest topical fluoride. She believes, or Miss Suarez believes, that topical fluorides are toxic. What is the most appropriate way to respond to Miss Suarez? Discuss evidence-based information related to topical fluoride therapy. All right? That is your job to do. If the patient still disagree, that's fine. She doesn't want a radiograph. Explain you cannot proceed without a radiograph. For an RCT, you need a radiograph, right? SHA, 38-year-old patient, clicking joints, cerebral palsy, taking several medication to manage that. Discuss various dental related issues, including clicking joints. Most conclusive diagnostic information, MRI for the clickings to see the disc position. Bilateral anterior displaced discs. What is the appropriate management for Mr. Shah? No further treatment is indicated because it's only clicking without any pain. So it's fine. Mandibular advancement splint we usually don't use, and this is used for patients with sleeping issues, sleep apnea as well. Okay. I mentioned in the last mock itself the indication for different types of splints and where which splint is used. But yes, if this option or this case had anterior reposition splint, then you can use that. Okay. Planning for extraction, imaging modality, CBCT. Which medication will be involved in causing the gingival swelling? Phenobarbital. All right. Gingival hyperplasia, drug-induced gingival enlargement. Again, this is interesting question. Again, a lot of ambiguities between different people who have answered this question earlier on Facebook and all the social media. Mr. Shah is missing tooth 1-4 and wishes to replace it with an implant retained crown. However, there is evidence of active periodontal disease in his oral cavity. Mr. Shah insists on prioritizing the implant over periodontal treatment. What is the most appropriate way to manage this situation? All right. A lot of people I have seen answering it A again and again. I don't really understand where do they get their concepts from. Your task is explain that you cannot proceed with implant treatment until the periodontal condition is stable. All right. That's the most important thing. And that is why, even in the portal answers, you will see why I've selected E. You can go with the patient desires as long as you're providing the right management as well, right? Like, for example, um, you're giving the option of RCT and extraction. Patient is not financially stable and wants to extract. You feel the tooth is very sound, but of course, the patient is in pain. You think the tooth can be saved, but the patient wants extraction. Now, going with extraction is fine. That's okay because everything has been discussed. Here, you see that there is a problem ongoing, a periodontal disease is there, and the patient wants implant without catering towards the periodontal disease. You can't go and place an implant and disregard the periodontal condition, as I see a lot of people on Facebook answering A, which does not really make sense. That's not how dentistry works in Australia. Please remember that. Phenytoin and phenobarbital, someone is asking me, is the same? Not really. Phenytoin is anti-epileptic. Phenobarbital is a barbiturate, right? Benzodiazepine. It's a different thing, right? All right. Next, Rutherford, schizophrenic, suffer from epilepsy, psychosis, mild intellectual disability. Came with his carer, her carer, sorry. Broken tooth 1-1, you take a periapical radiograph. Most important feature of tooth 1 that you should consider, tooth restability. All right. It will be difficult for you to restore this tooth. You think that there is an issue related to the bridge in the region 24 to 27? What is the most important diagnostic test that you should perform to assess the issue in quadrant 2? Periodontal probing, you can see bone loss. There might be pockets, furcation involvement. That's the most important thing that will help you with that. Phobia of needles, and as the carer has asked if treatment could be done under inhalation sedation, most appropriate advice you should provide regarding nitrous oxide sedation to Miss Rutherford. It should be approached with caution due to patient's psychiatric condition, of course. Okay. No, the thing is that, you see, someone is asking me why not mobility? What is the most important diagnostic test that you do? Mobility is not a diagnosis. Periodontal probing will help you get to the diagnosis of the patient's probably chronic generalized periodontitis stage, this and this, grade this and this. That is what you need here, right? Mobility, okay, it's grade 3 mobile. What is the diagnosis? Mobility is not a diagnosis, right? That's why I always read the question, what is the most important diagnostic test? Okay. Why not A in question 72? Okay, I have already explained. All right. So nitrous oxide, it should be approached with caution due to patient's psychiatric condition, right? Okay, someone is asking me, it is not better to send her to GA for question 73. Okay, let's read the question again. Miss Rutherford says she has phobia of needles and the carer has asked if treatment could be done under inhalation sedation. So, number one, they are asking you about inhalation sedation. What would be the most appropriate advice you should provide regarding nitrous oxide sedation? Regarding nitrous oxide sedation. okay, regarding nitrous oxide sedation for Miss Rutherford. So you say D, right? It is not beneficial and treatment should be conducted under general anesthesia. Not really. Why would you say it's not beneficial? It can be used for this patient, but with caution due to patient psychiatric condition, which means the caution can also include, after careful evaluation of the medical history, nitrous oxide sedation might not be used even. Understood? All right. So always this is, I think, fifth or sixth time that I'm telling you, cater towards what the question is asking you. Cater towards what the statement of the option is asking you or telling you, which answers the question statement. In which situation in general should we definitely go for GA? It depends. Patient medical conditions usually are not sufficient enough, but in children, of course, uncooperative behavior, behavior management techniques have not worked. So you will have to go with GA. All right. You determine that teeth 1, 1, 2, 5, and 2, 7, the later two being the bridge of require extraction, but the remaining maxillary teeth are sound. Considering the patient's current health situation, what would be the most appropriate option to replace the extracted teeth? A cobalt chrome partial denture, next best option. The medical condition would compromise implants. Resin bonded bridge is not indicated for the back teeth. For question 74, when can we choose acrylic if she has acquisition better option than cobalt? Uh, no, the thing is that you will be making sure that once you extract, the periodontal condition is stable, and then you will give them a denture, right? Now, let's say if the patient's carer or the patient themselves has said that they have financial constraints, then automatically it goes to acrylic partial denture, all right? But usually it's not the first choice. When we ask, where the case asks you what would be the most appropriate option to replace the extracted teeth, it means that something that stays for permanent. An acrylic partial denture is usually not considered a permanent option. Okay. Why are we selecting C over D? Okay. That's answered. Understood why a cobalt chrome partial denture is selected here. All right. Okay, after completing treatment, again, a very interesting question answered wrongly almost 100% of the time that I see on social media. After completing treatment planning, you assess that Miss Rutherford does not have the capacity to provide informed consent. From whom should this be obtained? The patient's legal guardian. A lot of candidates tell me, and I think this is in the ADC past question, they send me picture. Why legal guardian? Why not carer? Legal guardian and carer are not the same people. Carer is something that is authorized to take care of that patient. It can be an external carer where someone comes from outside, or an internal carer where the carer stays with the patient's family or with the patient. But a legal guardian is someone who's appointed to make decision on the patient's behalf. This can be the patient carer, but not vice versa. What I mean, a patient carer can only be a carer, or the patient's carer can be a carer as well as a legal guardian. Understood? But we can't assume that. So we go with the best option, which is patient's legal guardian. Okay? All right. Jenny Brown, 35-year-old, multiple sclerosis, initial infusion of disease delaying drug, ocrelizumab, flare up of mouth ulcer. I think exact same question is there in the portal. Category of drug that the ocrelizumab belongs to, an immunosuppressant. And again, you see, ADC is not really stupid. They know you are not supposed to know what ocrelizumab means. You are not supposed to know, all right? But they have already told you what it is. It's a humanized monoclonal antibody that works by targeting and removing specific B cells, resulting in the reduction of T cell activation. They have told you what is the function of this medication, and then it asks you to which category of drug does this ocrelizumab belong to. So if you look at the function, it looks like that they are acting as immunosuppressant, right? What pathological process is causing her the oral discomfort? Inflammatory, because of the ulcer, right? What deficiency can cause minor abscess ulceration? Vitamin B12. Benzodiazepine gel for topical pain relief. What is a concern for you to send the patient to a specialist if there is indurated margins, right? Given Jenny's description of the history of ulcer, someone is asking me 77, Dr. Raza, can you please explain? What pathological process is causing her oral discomfort? Now, if you see, it basically means what is the process that results in abscess ulceration? So it's an inflammatory process. It's an immune-mediated inflammatory process. It's not atropic, it's not dystrophic, it's not metabolic. Metabolic factors can be predisposing factor, but the process of how the ulcer forms is not metabolic. It's not infective again, right? So that's why the inflammatory option is selected, all right? Okay, Bashir, 36-year-old patient, occasional sensitivity, staining between the upper front two teeth. As part of risk assessment, important information, which is the most important one, dietary habits, of course. Dry mouth, suffering lately. Are you currently any taking medication? Number one cause of dry mouth. Miss Bashir is fully dentate and all the thermals are present and fully erupted. Given the findings from the initial clinical assessment, which diagnostic test is the most useful in assessing Miss Bashir Carey's risk? All right. Put in some explanation. Let's see what it says. Biotic radiograph, the most effective diagnostic tool for assessing proximal caries in early occlusal lesion, especially in posterior teeth. Panoramic radiograph, lower resolution, not sensitive for caries detection, because the case is asking you in assessing Miss Bashir's caries status. All right. Clinically, you notice that staining between Miss Bashir's teeth 1, 1, 2, 1 due to demineralization confined to enamel. What is the most appropriate treatment? Apply topical fluoride moderation and monitor. Further demineralization of fluoride toothpaste. Like, now this is interesting as well. I think I have mentioned something here. What specific oral hygiene aid would be the most effective in preventing further demineralization, which means further demineralization of what has already happened, right? It says, look at the question context, prevent further demineralization. Floss will keep the area clean. Fluoride will arrest and remineralize and prevent further extension. Okay? Which basically tells you why option C is selected here. All right? All right. Next case, Mariam, difficulty eating after losing her back teeth. Question 83. No, you don't probe pits and fissure, right? Probing is not really recommended because you can break off the enamel. That's very important. And you should have been knowing this because this is mentioned so many times in the caries file in the portal mock exams. All right, we don't really probe inside. And also, the thing is that probing pits and fissures, okay, you can probe one teeth or two teeth with a round end burnisher, but the question is asking most useful in assessing Miss Bashir's caries status. So you want to know whether it's low, medium, high. How will you know? Depending upon the recent lesions that you see on the radiograph, right? Okay. Clinical assessment of caries is more important than radiographic, someone is asking me. Now, you see, clinical assessment of caries is important when you plan to do something for a tooth and you want to know what can be done for that tooth. But that's not what the question is asking you, right? The question is asking you how would you, or basically rephrase this question in order for you to decide the caries risk assessment, whether it's low, medium, high for Ms. Bashir, what would you do? Okay. So just rephrase the question and then you'll understand why biting is important to help us detect the proximal and occlusal caries. So this is the bridge that this patient has. She has difficulty eating after losing her back teeth. Done a lot of bridge work overseas. Was unable to tolerate removable partial denture. would like to have an implant, medical history in April and ACE inhibitor, obesity, 10-month-old radiograph, which was taken overseas. You diagnose these radiopacities as exostosis. What is the likely cause? She is a heavy bruxer, of course. History of bone-related disease can be included, but option E will involve other areas as well, right? Bruxism plus the Canteler effect are known etiologies here, all right? You did BAPE and scores are given. Pretty straightforward. 2, which is option C. The systemic risk factor for gingivitis to progress to periodontitis, obesity. Investigation for implant placement, CBCT. It asks about systemic risk factor number 1, right? So you have only two options to select from, hypertension and obesity. Hypertension is not involved. Obesity can suppress the immune system and prevent the host response towards gingivitis in a poor way, which can progress to periodontitis, right? Again, the same question is there in the portal. So this was planning for implant, CBCT, 4-6 implant region, which anatomic structure would you identify? The inferior alveolar nerve, all right? Not really hard to select it. Okay, next case, what we have here. Starting infusion of a bisphosphonate, zoledronic acid, in 10 days. For initial assessment, you took a panoramic radiograph. What is the priority goal in Mr. Edgar's treatment plan? Extract any non-restorable teeth. All right. Again, this is an interesting case. You will understand why so many times in the portal I have answered it this way. All right. And why the answers that I've given are considered the standard. All right. What is the most appropriate change to delay the zoledronic acid until the dental treatment is completed? Because it says in consultation with his medical practitioner, Mr. Edgar's management plan needs to be altered. What is the most appropriate change? Okay. So you can delay the start so that any necessary extractions that can be done. Okay. 3-6 you want to extract. Local factor that could complicate the extraction, hypercementosis, as can be seen in the roots. All right. When obtaining informed consent for extraction of tooth 3-6, what is the most important action to be considered? Checking that the patient understands the information provided. That's the most important thing. You're concerned about Mronch. What is the safest time for performing the extraction to reduce this risk? As soon as possible before the administration of the IV injection next Friday. Again, so many times I've seen candidates, a lot of questions on social media from other people. They always select C, 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 and then the candidates tell me why I've selected B. Now you understand why I selected B is because it's important to get things done before the administration of the IV injection next Friday. That's the safest time. Nothing is safer once it's started. The safest time is everything before the injection, before the treatment starts. If it's on IV injection, then yes, C, right? That's correct. But here we are considering that the patient has not yet started. Question 93, Dr. Raza A for 93. Brittleness due to root canal treatment. It has been proven in literature the tooth does not become brittle, right? The tooth becomes weak because of loss of tooth structure, not loss of the hydration. So A is actually theoretically wrong. Yes, both roots have hypercementosis, but the question asking you, and the option that makes most sense says hypercementosis around the bulbous mesial root. That does not mean that there is no hypercementosis around the distal route. Okay. Next case, Andrian Cruz. Hepatitis 10 months ago, led to acute hepatitis B infection, never been vaccinated. Irreversible hepatitis diagnosis for 226. The treatment plan today is to extract tooth 26. You discuss with Andrian his general health and he shows you his blood test result from 1 month ago. What positive laboratory test result? Presently infectious with hepatitis B, HBsAg, hepatitis B surface antigen. You will follow standard precaution. Wear single-use gloves during the procedure. Basically, it's telling you which of the following is a standard-based precaution. All right. Reschedule him as the last patient of the day. You can't do that. It's a discrimination. If you say something like this in the practical exam, it's a straight fail. Be very careful. Read the article. It says so many times I've mentioned about hepatitis B. Standard precaution, no discrimination. Standard precaution, no discrimination. All right. So please be a bit alert, be a bit more aware on how things are happening. Okay. And this, like I said, 95 to 98% of the question in this paper are exactly as it is in the course portal with the exact same answers. Okay. So basically, the question is trying to tell you that what is the key precaution that you should be taken to minimize the risk of hepatitis B virus transmission from Andrian to the team and other patients. Now it basically says which of the amongst the option is a standard based precaution, because for hepatitis and HIV patients, we take standard precautions, all right? A, B, D, and E are not correct. Your hepatitis B antibody level is 98 milli international units per ml. What is the most appropriate post-exposure protocol you should follow in this situation after getting the needle stick injury? B is wrong. Why would you want to use a pre-procedural disinfectant mouth rinse? You have to use a bit of something that is important as a standard precaution, right? Is B more important than C? No, right? So this is have an assessment by an infectious disease specialist, all right? Although the 98 milli international units per ml is considered satisfactory, why we are not going with E and going with C is that complex exposure, especially involving unknown or high-risk source individual, and if the exposed person is non-immune. The patient is also non-immune here, right? What precaution is most appropriate for you to take? Undertake a refresher training on managing sharps. Addition to Hep B, what other standard vaccination should dental staff ensure they are up to date? Viral influenza. All right.